So earlier this semester, I accidentally got the minor cut on my hand, for which I had to go to the emergency room in a hospital in Philadelphia. After waiting for 6 hours without seeing any physician, I was disheartened that this is how healthcare functions, although I have health insurance, in a country offering some of the most advanced medical care in the world. However, my problems clearly pale in comparison to those faced by a majority of people in this world while trying to access healthcare. For example, let's take the Indian healthcare system, which is renowned in the international context for its numerous challenges, including little government financing, poor health indicators, inadequate healthcare infrastructure, and insufficient trained medical staff. India faces challenges because of its geographical size, its large population, and its vast socioeconomic and cultural diversity. The large health inequalities render some populations specifically vulnerable, and one of these populations is the Narikuravars. So who are the Narikuravars? They are a semi-nomadic group originating from North India and numbering 30,000 individuals. They now spill over state borders, but mainly live in Tamil Nadu in South India. They are identified as gypsy population, having similar roots and culture as other Romani communities, and at times facing the same type of stigma. Similar to other gypsy groups, the Narikuravars are an understudied population, and no formal study had been previously done about their health status and health access. Generally recognized as having a low socioeconomic level, the Narikuravars struggle with high levels of illiteracy and unemployment and low access to public services like healthcare. Traditionally, the Narikuravars are hunters, but since hunting was outlawed in India, the group's main occupation became selling homemade beaded jewelry like this one's, or cheap plastic products at festivals and around temples, with part of the community employed in jobs such as collecting garbage. Given their poverty level and distinct culture, they are oftentimes marginalized and even ignored in day-to-day situations, and their main interaction with the people outside of the community is through their small businesses. So in January, I traveled to Chennai in Tamil Nadu together with my advisor, Dr. Krishna Ivana Dragomir, and we conducted interviews with Narikuravar women from the community using a semi-structured questionnaire method, together with a team of local interviewers that we trained. We tried to observe the interaction between education, gender, semi-nomadism, socioeconomic status and discrimination, and its effect on preferences for care, health-seeking behavior, and access to healthcare. So what were our main findings? So firstly, education is an important factor impeding the community's access to healthcare. The community has a low education level, with a large majority of women we interviewed never having finished primary education. This makes it difficult to access and transmit written information about health programs or good health behaviors, relying instead on word of mouth and sometimes on radio and television. There are also issues concerning language barriers. The community speaks Vagriboli, their community-specific language, and informal Tamil, which is the state language. However, information is usually transmitted through mass media in formal Tamil, which they might not understand. Education also seems to create a hierarchy within the community. As one of the women we interviewed remarked, only the more educated Narikuravar families access health because they understand better how they should do it. We also found that some uneducated women feel vulnerable in a medical setting because they cannot understand the medical decisions that they have to take. Secondly, another factor playing a role in the Narikuravars' access to health is their semi-nomadic character. Most of them have to travel every day to find work, so oftentimes it is difficult for them to find out about different health services offered by government, such as vaccination, creche for the children, or health insurance, since this information is usually transmitted through house visits by government and social workers. This highlights the importance of informal networks. Information gets transmitted to the community, and sometimes through informal leaders, who are more knowledgeable about finding the community members, even when they are on the move. Nomadism and low education also form a vicious cycle. The high poverty level of the Narikuravars, partly because of their low education, makes it necessary for them to travel for work. But as they travel, they also have to take their children with them, so their children can't attend school on a regular basis. The third interesting finding is that the Narikuravars are very open to using allopathic medical treatment, although their community is renowned for using natural medicine. However, they have a low rate of utilization of allopathic care, which they almost never frequent for chronic and non-urgent medical situations. Besides the previously discussed low education, nomadism, and lack of information, issues that may prevent some Narikuravars from accessing health. The women we interviewed also report structural issues within the healthcare system that make the experience of accessing care more difficult. They have faced issues related to discrimination, disrespect, low quality, and being asked for bribes in the public sector. Therefore, some of them prefer using the private sector, although they may not afford a high out-of-pocket cost and thus have to take out loans or go into even more poverty. Additionally, a majority of the women we interviewed were familiar with the concept of health insurance. Their low income, generally under 72,000 rupees a month per family, qualifies these Narikuravar families for state-sponsored health insurance. However, only around 30% of those interviewed had the Chief Minister's Comprehensive Health Insurance Scheme, which is the state-sponsored insurance for Tamil Nadu, and the utilization rates were surprisingly low. Only 5% of those with health insurance declared that they had used it. And one of the main causes for this that we discovered is that they had a long waiting time and bureaucracy involved in getting the health insurance card or other government documents, which can take more than 8 months. Moreover, many Narikuravars felt like it is the government's job to inform them about applying for health insurance given their low education level. But so far, the government awareness initiatives have appeared relatively ineffective. The low utilization rate is mainly due to the lack of education about what the insurance covers and how to use it. Some providers may choose not to accept insurance, which creates further confusion, a lot of time wasted in transit between hospitals, or also being charged for a service that Narikuravars thought was free. Let's talk about discrimination. The Narikuravar community faces a high level of stigma in the Indian and Tamil societies. Their community is associated with being poor, being dirty, uneducated, gypsy, and most people try not to touch them and stay away from them. Some of the discriminatory practices the community faces were being denied access to healthcare, receiving bad treatment, and being humiliated by the medical staff. The community therefore faces a double layer of vulnerability: their lack of education and low socioeconomic status, and the stigma against their cultural origin. So, to conclude, it is vital to understand the demographic and sociocultural dimensions of access to health for marginalized groups like Narikuravars in order to create more equitable policy and welfare programs that will provide access to health for the most vulnerable groups in India. There is also a need for better understanding of healthcare system design, in which marginalized groups like the Narikuravars are sometimes excluded. It is only by having a multilateral, complex understanding of the Narikuravars' experience in the healthcare system that their access to care can be improved.